Thank you for staying with us. You're still watching The Breakfast on Plus TV Africa. The Nigerian Association of Resident Doctors, Nard, has criticized the National Universities Commission, NUC, for upgrading pharmacy, physiotherapy, and optometry degrees to doctor status, calling the move potentially harmful to Nigeria's healthcare structure. While the NEC argues that the change aligns with global best practices and aims to strengthen clinical training, Nard warns that it could confuse patients, enable quackery, and strain interprofessional relationships in an already delicate system. They insist that diagnosis and treatment remains the exclusive domain of medical doctors. Nard further emphasized that no developed country equates pharmacists or physiotherapists with medical doctors in title or salary. The group urged healthcare professionals to value their unique roles and warned that professional rivalry should not overshadow efforts to improve the health sector. And then joining us this morning is Dr. Tuyi Mebawondu, is a public health practitioner, and Dr. Oludare Akinlaja is a managing partner OAR&D Company. Good morning, gentlemen. Thank you for joining us. Good morning.
Good morning. Thank you for having me.
Thank you so much. All right, so Dr. Tuyi, I'd like to start with you right now. Of course, Nard is saying, no, we don't think you should give this doctor status to, non-medical, still medical, but people that have not maybe earned it as much, because obviously they probably do not have to spend as much time in training compared to the medical doctors. What do you think is the rationale behind the NUC even trying to give this title to optometrists, physiotherapists, and pharmacists in the first place?
Well, thank you so much. Let me be clear. I am not diminishing the intelligence, authority, or the thinking behind the decision of the National University Commission. Because normally we expect that organ of government to be populated by a lot of intelligent people and professors. But let's look within the Nigeria health system, okay? If you look at the critical problems within the Nigeria health system, nomenclature will be the last thing that we take everybody will look at, okay, in the sense of training. Nigeria have deficiencies in training of every cadre of network. Of course, worse even for pharmacists, worse even for physiotherapists. Now, you ask yourself the question, why this sudden change of trying to label everybody doctor? Now, think it's Nigeria. Even this Nigeria, people like if every person that is having a selling drug is called a doctor. Everybody you see as a male within the health system is a doctor. Every male nurse is called a doctor. You see that big confusion happening in terms of identification and even the role you are going to play. Why then further confuse it? If you want to streamline and make them more effective, they can still be who they are and be effective. It's not about the name. But of course, you know that guy is really obsessed with being known, being called a doctor, being called a professor, being called this general, being called that general. We shouldn't push that into medical profession. And here's why. Let me tell you, all these other branches, whether you call them physiotherapists, whether you call them pharmacists, or whether you call them, whether occupational therapy, whoever you call them, all of them are resident in medical profession. The doctors do not actually do all this work, or the doctor choose to train this person, you go and become a nurse, you go and become a physiotherapy, you go and become the pharmacist, and then work with you in such a way that you can deliver their services. Now, we taking them away from that control, because whatever structure you have, there is this for control, there is this for orderliness. When you are not trying to take away from that control and orderliness and trying to create a new model, a new model for them, you are going in a country like Nigeria, you will cause a lot of professional rivalry and infractions. That prevented the medical system from. So why do we do this in Nigeria? Everybody just want to become, get a title and the creating confusion in the health system. It's not tidy at all, as far as I'm concerned.
Interesting. Okay, so Dr. Oludare, Dr. Tuyi just said something that spoke about professional rivalries, right? How do you think the government here should have approached this in the first place? And would you say that maybe this is just semantics? Does it show a deeper issue or reflect a deeper issue with this sector here, whereby they just say, you know what, you can become a pharmacist, you're a doctor, an optometrist, you're a doctor, whatever you like to do, you're just a doctor. How can they ensure that there is balance, you know, in this having to hand out these titles whereby there is no professional rivalry here?
Thank you very much. To do this, hit the nail on the head. And you see, because of the peculiarities and the nuances in our environment, now there's no problem with that. So, for instance, in America, I think you have things you call family in particular.
Yes.
So, in systems where
there's even siding. Yeah, I was even saying there's even siding whereby you're a psychologist and you can have a doctorate, so siding as well. They just hand out these titles.
Yeah, so the environments are highly regulated environments. If you are not supposed to be seeing a patient in a particular area, and you are caught doing that, so in environments where there's a high sense of regulation, that's okay, but in an environment where even people who are not nurses are calling themselves nurses, and people who are not supposed to be in certain areas are calling themselves things in those areas. So, like I would always say, we need to begin to deal with things in context. Nigeria is a peculiar context, and I think we need to hold the brakes a bit on giving nomenclatures to people who are not probably full doctors or doctors in specific areas, so we don't have problems. I don't want to say things on television, but there are people who have had cases, medical cases, being treated by people who say they are doctors and don't have proficiency in that area, for instance. Now you don't want to allow random people, apologies to people who, the idea is that it's a system of gatekeeping. Let me use that word. Giving that nomenclature to certain people is some sort of gatekeeping, so you don't have just anybody make a claim that he can do what he's not supposed to do. It's the same argument when you see somebody who is an engineer or an electrician on the road wanting to call himself an engineer. All those things are dangerous things. There's no problem with it, like Dr. has said, but our environment is not mature enough to remove the gates that you have put as a block to regulate just anybody being called certain things in certain spaces. So I think that's going to be my point, and I think the government should look at it holistically. I'm not even sure there's any sort of rivalry in that sense. That's a silent undertone. But even for the Nigerians themselves who are going to be engaging, the health system, we need to be careful not to create a process where people cannot properly identify what people are supposed to administer in that sense.
But does the title matter? Dr. Tuyi, I'll come to you now. Does the title even matter as long as they're doing their job? So if I'm a pharmacist, I know that this is where I'm operating, and this is just a title that I have, whereby my name would be Dr. Rume Paulson. So does it even matter? And maybe to play devil's advocate here, can we look at, is there any pro to this? Because I think right now we're fixated on what the cons might be, but is there any pro to this at all?
With respect to, I don't know the thinking behind it, but anytime I hear about upgrade, now I'm making cross-reference to other industries. It's usually because probably people want to set a new salary structure or want to give some sort of accolades or what to certain professions, and that's okay. But like I will say, the health profession is too sensitive not to have certain gates, so people don't represent what they are not. Especially Nigeria, where we really are not too regulated, and the level of literacy to people, people in the rural areas, elderly people, people who just, I went and I saw a doctor. Did you really see see a doctor? Did you really see? All those kind of questions. We may not really be able to ask them in our environment as it is. So I'm not saying that there's anything bad in that sense, but for gatekeeping issues with respect to our current predicament in Nigeria, I think we should be slow to making that decision. We need to look at the after effects, because just like in policy or in strategy, every decision you make has its pros and cons, but you need to look at the underlying effect of that decision. Will it not cause more damage and danger to life if we remove the gates that serve as boundaries to that decision?
Yeah, I understand what you're saying, and especially because lives are at stake here. This is what we're talking about, and it's very sensitive. For instance, you cannot just be a nanny in the UK because they know that it's childcare. There is a life attached to that. So there are certain things that you cannot just do, and we have to be sensitive to it. So like you already said, if you go and see a pharmacist give you a medicine or something, do you just say, well, I really went to see a doctor? And yeah, I get it. But what do you think, and Dr. Tuyi, I'm coming to you now, what do you think we can do to ensure that, there is that collaboration with everybody, and we don't even have to alter these titles? It can still stay the same. But how do you think we can all work together, especially in the health sector? Hello, Dr. Tuyi. I think you might be muted. Would you like to unmute, please?
Can you hear me?
Fantastic, I can hear
Hello?
you now. Yes, sir, please go ahead.
Okay. Can you hear me now?
Yes,
Can you
sir.
hear me? Hello? Now, I'll give an example that will just let you understand the perspective. Okay?
Yeah.
Now, look at the media, Nigerian media space. Okay? Now, this media space is actually helped, and maybe few media practitioners like mass communicators. Look at what has happened now. Everybody is a journalist. That you see the chaos in the media space, you cannot regulate, you cannot manage, so many things are happening. So now, if you push that to medical profession, the chaos will be worse, because you won't be able to distinguish who is doing it, who is doing that. Now, essentially, everybody must stay within his beat and understand that, listen, I am a pharmacist, and my work is actually to follow an instruction given by a doctor on how a drug should be used. I'm a physiotherapist. I'm essentially to follow a doctor's instruction on the kind of exercise I have to put for this person who is having heart problem, or for this person who is having, neuromuscular problem. So all this instruction actually flow from a doctor. He will tell you to do this. Now, as a physiotherapist, you have to actually deepen and have a way to discuss with the doctor on what other aspects you to put. But by saying that, okay, physiotherapy is not a doctor, a nurse is not a doctor, occupational therapy is not a doctor, everybody within the medical profession is a doctor, what kind of confusion are you causing? How do you want me to, my grandmother or my mother, to perceive that in the village? How do you want my people to understand that a nurse that's brought to them, and a physiotherapist that's brought to them, who is not a doctor, cannot actually attend and even examine patients concretely? And if you look at the training, in fact, the training is quite distinguishing. If you look at the training of a doctor, it is very thorough in every aspect of what we are talking about. It's thorough in human examination, it's thorough in physiotherapy, it's thorough in pharmacy. You know all the drugs, how they type, and how to relate the one you cannot prescribe for this and that. The first point comes from the doctor to decide what you need to do. So why are you now trying to create, whoever is taking that decision, I wish them luck. But from Nigeria, from what you have seen in Nigeria, in future, very soon, you see that chaos, and it's, in the whole health system. We have not trained enough. We're training less number of doctors, maximum 3,000 every year. We're training.
Hello, sir. I think
less number of pharmacists and nurses. We're not focusing on that to even deliver primary health care to people. We're looking at how to change titles. Well, everybody can be Dr. Mr., Dr. Chief, Honorable, Professor, this and that. That's up to them. But it's going to change. As I'm sure it will change the quality of healthcare in Nigeria. It won't.
Well, I think I kind of agree with you because, I mean, the confusion, a lot of people can just go and see a pharmacist now and they think I don't need to see a doctor. Meanwhile, it's a doctor that needs to give the instruction to the pharmacist that these are the medicines you should give out. And the pharmacist just says, you know what, this is what you're taking. You take it 3 times a day, whatever the case might be. But there might be that confusion whereby people just say, oh, I've seen a doctor and that works. That's fine. I don't need to go see another type of doctor as long as a pharmacist can give me what I need. But Dr. Oludare now, right, how can we maintain or incorporate global practices? Like you said, in the United States, for instance, they do this, but we have our own nuances that changes everything. So if we're looking at the local realities of Nigeria, what can we do to harmonize the best global practices and just still ensure that even with the current realities or the local realities that we have, it still works?
Okay, thank you. So maybe I should put my own disclaimer. My own doctor is not a medical. So they don't call me for fitness. But it's the same thing even in academia, right? It's the same fight of, oh, your own doctorate is academic, mine is professional, there's a difference. You know, so all of that really is just gatekeeping. And you know, I keep hammering the word gatekeeping for standardizations. Now, you can say it is the same in America, but in the UK, it's different. You know, the UK and Nigeria, I think I did similar in how we do things. And that's because of these regulatory things, right? And when you say global best practice, to me, my opinion, as far as it has nothing to do with the technicalities of the role, right, which Dr. Tuyi does, which is a very great job in the cases of it. So you have Dr. Tuyi who has gone to school for so many years, you know, has done his first general practice, has now come to focus. Even the time spent in training should be a factor to distinguish these things. The time spent paying attention to these things should be a factor in distinguishing them. You know, so I just think we should global, even in other fields, when we talk about global best practice, they will ask you, how do you contextualize global best practice as far as it is not with technicalities? Because the ear is two globally. I don't know whether there's any part of the world where the ear is one, or where the veins are different or the nomenclature is different. That is on the technical side. But when it comes to the social issues and the management of the social nuances and all of that, I think we need to be careful, because this title thing is big on the social aspect of it, the cultural, behavioral, and policy side that will create an offshoot of problems. I'm not sure having to do with whether if the technical side, because what I always like to do is to ask my doctor friends certain questions, and I'm careful not to give certain examples, so it doesn't look as if you are playing down on the rules of other people. But if you know what it takes for a doctor who did a general practice, after finishing, they now focus, there's a wider scope in the sense of understanding what an issue is compared to other people. That alone is enough bias to tell me that we should be careful in how we just give people names, so we don't offset something that is even orderly for now. You know, we're even struggling to maintain order as it is. Let's not create more disorder in the wheel by bringing in a factor that will give us problems.
Well, Dr. Tuyi, I don't know if you have any final words on, you know.
Let me ask something. Let me ask.
Okay.
Yes, I want to say something. Let me just buttress your points. Now, you know, this is how the changes to be those days. Okay, up to these funny things. I finished my training over 3 decades ago. Now, if you are a doctor, I have done medicine, I've spent 7 years in it, and now I needed to look at some specialization. What we need to demonstrate is that when a doctor that has done that 7 years will go back and dig deeper clinical pharmacology and different pharmacy, and do a deeper level so that he can start relating to pharmacy from the perspective of that medical training, okay, and then direct how drugs are going to be administered at a higher level. Then you also see doctors now who have finished that level going further to do laboratory so that they can do a deeper understanding of laboratory calculations as the case will be. That or even occupational therapy. You see, I can tell you my professors, my guys who are actually, even my mates who are actually into laboratory practice and have done study medicine. I think this thing came because now we have some other guys who wanted to just be equal to doctor, now who not gone through that training, that's 7 years or 6 years training, that's 6 years. Now they just want to be doctor and then they are pushing, pulling, doing everything, containing, threatening. That will not be happening. If you want to honestly be a clinical pharmacy, yes, study medicine, go back. I have a professor at brilliant gender guy who did from artificial medicine, now went back and then do clinical pharmacology and clinical pharmacy to even apply to the patient. I know there's anybody who is not still with her, and as a professor in microbiology. So I don't know how all these things can come up. What we just question is that the nurses will also say, no guys, you are going for physiotherapists, you are going for pharmacists, it is our turn, it is our local. So this is the kind of thing I'm going to get. Chasing title, chasing names, and empty deliveries everywhere. We shouldn't go this far. It's not any damn international best practices. I mean, where which best practices? Is it the same in Germany? Is it the same in UK where we operate medicine? So what is the best practice we are talking about? Even in America, it's simple. Because now, like Linda mentioned, it's a regulated environment. You mess up, you run into trouble. Even in this place, when you mess up, you still walking the street free and contesting the election, and because you're being appointed elsewhere, you want to introduce that to the medical profession, you get chaos.
Well, I mean, I understand what it is like, because of course we do not want the confusion, we do not want the quackery. We want people who can have these doctor titles to be well trained, and of course the people who are even going to seek this medical attention, they know what it is. So I don't know what NUC was thinking in the first place, but I'm sure it's their own job to think of ways they can just change things up. So with this, Nard obviously is opposing it. Let's see what happens, and I'm sure you guys, both of you, have made your points why we should not be looking at this. Leave things as they are, and if you want to be a doctor, go for that formal training, be as professional as possible. You can get that. If you want to be a pharmacist, don't just say because I'm a pharmacist I want to get the doctor title. So we'll just see what happens with this. But gentlemen, this is how much we can take on this segment right now. I want to say thank you so much for coming. It's been a pleasure having you. Thank you for your time.
Thank you for having us. Thank you, doctor. Thank you.
I'm sorry for the internet.
It's okay, sir. Thank you so much. Have a wonderful day.
Thank you so much for the network. Did they allow us to have a proper discussion of the thing? Thank you so much.
Thank you, sir.
Thank you.
All right, so we're speaking with Dr. Tuyi Mebawondu, is a public health practitioner, and Dr. Oludare Akinlaja is the managing partner, OAR&D Company. And we'll just be looking at the fact that Nard has rejected the doctor title for non-medical health degrees. We'll go on a short break now. When we return, we'll be discussing our second hot topic. This one talks about starvation in northern Nigeria, so please stay with us.